So, welcome back to another episode of IBD Essentials. Today it's a great pleasure to have a good friend and long-term colleague of mine with us, Professor Andreas Sturm from Berlin. He is head of the Department of Gastroenterology at the DRK Kliniken in Berlin, and he is a long-time expert in guidelines. He was GICOM chair of ECHO. He is currently responsible for the German Crohn's disease guidelines. He was working in the UEG, also in the quality of care task force. And I think guidelines are really something important. And I would like to discuss with you, Andreas, about the importance of guidelines. What is about all the heck of the guidelines? Perhaps you just tell us why you started to get involved into guidelines, why you got interested in this topic, and then I think we will cover some of the issues with the guidelines. Are they really that good? Do we need them? Do we not need them? Are we restricted by using of guidelines? But first of all, why did you start with the guideline work?
Axel, first of all, good morning. Thank you very much for the possibility to come here. It's a pleasure to talk to you in the next, 20, 30 minutes, we will see. Guidelines, indeed, it's a very controversial topic. And like 15 or 20 years ago, I thought that inconsistency in treatment was something which bothered me. Someone is going Crohn's disease, 5-ASA, high dose, the other one is doing this and that. And so the belly feeling of treating patients is something which I thought is important to stop and to treat patients more consistent. And then something you brought me up working at the European community and UEG. My first guideline meeting was indeed in Germany, and I never forget that we were sitting there in a group of like 20 or 30 people. We discussed about something surgical, and then we came up after 50 minutes to a very, let's say, tight compromise. And then a German famous professor stand up, raised his hand, and said, "You can discuss it whatever you do. I do it differently in my clinic because I'm IBD surgeon in Germany." So I thought these times are over, and what we have to do, we have to improve patient care and first of all, consistency all over Europe, all over Germany, all over the world, that a patient is treated on the same way, which is based on scientific evidence. And I think that's what guidelines are for, to bring scientific evidence to healthcare professionals to enhance patient treatment and to provide a consistent treatment in a given situation.
So to bring this in a nutshell, you started probably because you wanted to move from eminence-based medicine to evidence-based medicine. And as you have experience in different guideline systems, European, German, there is always this discussion. There is a lot of differences between the guidelines, between the different countries. You know a lot about the methodology. Can you tell us how the evidence is generated or how these processes work to get the evidence and then rank it and then come up with some of these statements we all know?
This process is done a little bit differently. And, guidelines are criticized for many, many things. I think the most important positive thing that it enables us to bring all the given scientific evidence together and make recommendations out of it. Guidelines are not a cooking book. It's not that a bad physician can take the guidelines and make a perfect IBD treatment, a perfect cancer treatment, or perfect liver treatment. They are, let's say, guidelines given by evidence. So it is very difficult to find the right evidence. As I said, there are different methods. One is, of course, Oxford, one is great. There are different systems to rank papers, manuscripts, what kind of level they are, 1, 2, 3, what is the quality, and then bring it into the recommendation. For example, when a pharmaceutical company is, of course, making the study design and, let's say, make everything only per protocol or intention to treat, there are two different outcomes. Treating through crossover designs, all that we have to take in advance, or to take in our thoughts, to make a good paper, take it and make a recommendation out of that. There's also a lot of pressure, of course, to put this paper in, to put the other paper in, to make this evidence stronger. And this, for example, especially when it comes to drugs, when two drugs are compared, A and B, of course, we look very, very carefully if this study is really well done and if you can really make a recommendation out of that to make this priority A, to make the other drug priority B. And this is something we were very criticized for in our guidelines, that we don't give clear recommendations for situation A, B, and C. We give possibilities.
I think this is a very important topic we will probably discuss a little bit later on. First of all, you already mentioned it. It's a very complicated process. We use different clinical studies, trials, and what I recall is that the highest level of evidence is meta-analysis, and then we have randomized controlled trials, and let's say very down is like a case report. So usually if you have enough evidence, you will not even use this, but certain situations probably you have to use it. Is this correct? So that you rank this?
It is correct, but I think it's not the point 100% of a guideline. A lot of people criticize this. You didn't put this paper in, you put that paper in. But these are people who don't like guidelines at all, because the guidelines are not doing what they said. They're using a drug for 20 years. I always use infliximab in this situation. So, for example, when we speak about IBD, and then I said, why? And then said, I have my most experience with it. I use it in 20 years. That is something we should overcome. We should, make patient-centered medicine, patient-oriented medicine, and using the drug with the best evidence of the given situation. And that is consistency, and I think that's what guidelines are for. It's not, in my opinion, important how much a paper was ranked. There's so many IBD papers out of the market. If you take one in or one out, it doesn't change the whole method.
But sometimes it may be changing. We have a systematic research, so we get all the papers. These papers are validated. They are put into different tables. So it's a very complex process. So this is one part of the process. But can you tell us who is involved in the guideline process, in the Delphi process, in making these opinions? How are the people selected? Is it just you and me, or who is participating? Is there, for instance, also patient involvement? And
they changed over time, fortunately. In old days, some people came together, called other friends, said, let's do a guideline together. These times are over. Now it is the societies, the medical societies who propose people to come. So you can propose and be member of the group, and then you have show evidence that you know about IBD, about liver, whatever. And then this group is put together. Then we have different groups. You'd say treatment, diagnosis, whatever. What is there? Complicated system, extraintestinal manifestations. And then we are looking for the literature. And the literature is graded by other people also. It's not only us as physicians who do it. There are other independent groups who are looking for so-called PICO questions, so important questions which are answered by the papers. So it's not only us who decide this is a good paper, this is a bad paper. And then we have the evidence. And this evidence is graded. And then from that evidence, we make our recommendations. So and then we put the recommendation in the big group with the Delphi process. And everyone can give his comment to that, which are a lot of people there. And then also, as you said, patients are involved. So it is very important that we always have patient involvement. Another sidekick is that the guidelines are now all translated into plain languages, speaking about patients. So this is very important. One purpose of guidelines is also patient empowerment. So the patient can read it in plain language and discuss with the physician about his treatment. But this is a sidekick. This was not your question.
And I think it's very important that at least in Germany, we have different areas of caregivers. So we have patients who physicians just treating outpatients. We have surgeons, we have radiologists, pediatricians. So to have a really comprehensive working group with a lot of experience.
No one is let out. Everyone can apply for guidelines.
One important part about these guidelines, and you mentioned this, is they are not a cookbook. So I heard a lot of criticism. I have a situation, this and this, a patient, this and this, and do not find anything in the guidelines. Probably you can allude a little bit. Why is the guideline not a textbook and not covering everything, and it's not a cookbook? What is the real deal of the guideline? Who should read it? What should be done with this?
Who should read it? Everyone. Everyone who's involved in the treatment, and probably no one did. But it is only the reflection of the given scientific evidence. So if there is no evidence for this or that situation, this cannot be described. It's not like a textbook where the author said, oh, in this situation, I would do this and this and that. That is not the purpose of guidelines. We cannot do it. That's against the idea of a guideline. If there is, for example, an extraintestinal manifestation, we can say this is the situation, you should look for this and that. But if there is no recommendation, for example, methotrexate or whatever, we can say there is no recommendation. So if you use it or not, it's up to you. But it's not that we are saying you should use 300 milligrams week 0, 2, and 6. This is not the idea of a guideline. They're like a guidance through the treatment, and should help you and say, oh, should I use, for example, 5-ASA in a small bowel Crohn's disease? And you look up it, there's no evidence. Okay, and then you stop treating that. That is important, like guidelines, but not a cooking book. You cannot make a good cook just with a cooking book. You need experience for treating a patient well.
I think this is something which is very important, but you mentioned probably it's very good. And I think for the majority of situations, you can cover everything with the guidelines. So if I look at the ECHO guidelines, for instance, you will probably cover 75% of all situations of all patients. But you already said everybody should read it, and we both know that just looking how the implementation of guidelines work, it's probably not 100%, and sometimes it's also really cumbersome. If I look at the guidelines, if you take all the ECHO guidelines together, it's probably 1,000 pages because there are so many guidelines, not only on ulcerative colitis, on Crohn's disease. There's one for endoscopy, one for histology, one for pregnancy. So any ideas from your side how you can help to implement these in the clinical practice?
I think what I do is recommend to look at the specific given clinic situation, then look up in the guidelines. So for example, you have a patient who is failing a treatment, for example, then you look up in the guidelines for this specific situation. For liver disease, you have this and this configuration, I should now test this. This is what the guidelines are for. I think they're not there to read it from A to Z. No one does it besides me or other people who are involved in that. But it gives you a very, very good idea that you should not do this. If you have a patient on, let's say, biological treatment, you should check every 3 months on liver enzymes and sugar and kidney and so on and so forth. I think they clearly give you guidelines. And if you start with a biological, for example, you should take your time and read the guidelines with this chapter biologicals. Otherwise, you don't know how often you should check for whatever anti-drug antibodies and so on and so forth. So I think everyone who should be using it is treating a disease should be aware of the guideline.
This is what I always tell my fellows, for instance. It's very simple. If you have a patient, let's say, with proctitis, you can just look up proctitis, and there are 3 sentences. If you would like to understand these 3 recommendations, yes, you can read the accompanying text, and these are 2 pages, and then you know all the background. So probably this is something which is very straightforward. What do you think about implementation using apps, for instance? I know that ECHO and the German GI Society, for instance, UEG, they have created wonderful apps where you can, even on the bedside, just look it up. Is this helpful? Do you use these sometimes, or?
Yes, we use it. I think the most threshold is for people to look things up and not ask the professor or doctor, how do you do it? So look up for really scientific evidence. And if you're a young doctor, I think it is very important to build up your own opinion, not living on all the opinion of other people's. So primary source is a very, very important thing. Look in the app, look in the guideline, look in the browser, whatever you find, but look for scientific evidence. However it is digested to you. The apps are all different forms of digesting it easier and easier and easier. I think at one level, medicine is too complex to just make proctitis in one sentence. You need 4 or 5 minutes to read it, however you digest it.
I think with AI and machine learning, everything, this will be probably even easier, because I think when you give in Google, how do I treat a patient with proctitis, they refer also to guidelines, and this make it easier. But we all know that the quality of these artificial intelligence programs are sometimes not perfect. Any thoughts about this?
Yes, but we do have programs now which have limited resources, limited sources. So you cannot look up on Google or on AI how you treat proctitis. But we do have now good programs where the source of AI is limited to specific scientific evidence, like guidelines or PubMed. things like that. So this is better. This is significantly better than Google, which is usually 2 or 3 years old and not good.
Yeah.
So if you use AI, use a professional medical AI, which is available at your hospital, your private practice, should buy it.
Yeah. I think it's a very good thought, and this has to be considered. One important other aspect, you were also a member of the Quality of Care Task Force of UG, and I personally believe that guidelines could also be used to enhance the quality of care and even assess the quality of care. We are both from Germany, and we know that in Germany, for instance, all the cancer centers have translated the clinical guidelines, for instance, for colorectal cancer in quality measurements, and you can measure this. Do you feel that this could also be something for IBD? So talking about surveillance, colonoscopy in patients with ulcerative colitis, sometimes we see that it's not done. Patients treated with steroids for 20 years, and the guidelines clearly recommend you should not do this. Do you think this could be implemented to improve the care of patients?
100%. I think if ever you go in the world and you had said that you should look for, let's say, colonoscopy every 3 years, 4 years in a UC patient, then you can go, whatever level you are in medical, if you're a young student, if you're a young physician, you can go to your supervisor and say, in the guidelines, it says you should do it every year, you should use it with special light, or you should do this and that, and there's a clear evidence. So this patient you take care of is enabled to best medical treatment wherever you are, in this corner or that corner of the world. So this is very, very important that you said this patient, after, let's say, 3 months of steroids, we need to taper it. This is evidence, and you don't have to look up in 20,000 papers. There the evidence is written. You said you should use for a remission drug, let's say biological or JAK or immune suppressive drug. Very, very important.
So this is one thing. One criticism about the guidelines, and we touched upon this a little bit, is when we started, for instance, they were updated like every 5 years. And especially in the area of IBD, we see we had like years where there were like 3-4 new medications, and a lot of people who are not really into the field were saying, oh, this drug X and Y is not in the guidelines, I cannot give it. Can you just spend a few words? Is the guideline a Bible and you have to do it? And what are the changes that have occurred in the past to really be more frequently updated guidelines so that they are really up to date? For instance, the German way.
Speaking of the Bible is a couple of thousand years old, so it's probably not that we want in medicine. But we do, in the first inside, we do living guidelines. So every year we do an update. So we are sitting together for 5 years. This is the validation date of guidelines. But every year we're sitting together and see what kind of new evidence is here. It's mostly about drugs. And say, okay, this drug is on the market. What is the evidence? And then every year we change it in a short updated version, which is, I think, very, very important to really be up to date. And that's what we didn't do in the last years. A lot of criticism that it was very, very old. The guidelines take a long process. The Delphi process take a half year. Looking for all the papers take a half year. Ranking the papers. That's what I just illuminated a couple of minutes ago. This takes years, usually like 2 or 3 years. It's a big pain in the butt, Axel, to organize a guideline. Then it comes on the market, and then it's published, and then it's already 2 or 3 years old. That's the reason why we need updated. But I'm not quite sure if this drug A or B is really important in a guideline. It's more an idea of starting, for example, a biological therapy, changing it after loss of response, after 12 weeks, things like that. I think that is more important than taking this drug or that drug. It's more a way to treat your patients.
Yeah. I think this is very important. And I would like to move to another shortcoming, and you mentioned this earlier, and I suggested to pick it up again, and this is sequencing. So we have now so many different treatment options available, and a lot of people who are not daily dealing with IBD patients ask for a sort of guidance to tell them which drug should be the first-line drug, second-line drug, third-line drug. And the two of us know very well why this not really can happen. But what are your thoughts on this? And sometimes we even have a little bit different opinions on this, so we probably can discuss this a little bit.
Of course, it's a wish of every physician to say, "I'm this situation, you should take drug A." Let's say TNF blocker when we speak about IBD. But maybe it's a different situation. Maybe that patient is this and that situation, so you have to use this and that drug. If there is no study, guidelines can give no recommendations. So you need a study where you have a first diagnosis of IBD, always the same patient, then treat him with anti-integrin, anti-IL-12, anti-23, anti-TNF, maybe a JAK. And then we have 5 groups of every patient has 100 patients, treat him for half a year or a year, and then you have the outcome. Unless this study is done, we cannot give recommendations because all studies are different. Even though the company are saying, my drug is the first, it's better than the other one, if there is no clear evidence. And I think it's very important that we push the pressure on pharma on ourselves to do that studies. We cannot do placebo trials anymore, with drug A against placebo. This is not medical standard anymore. We need drug A against drug B in a given situation. So we have to push the companies, and if they're not doing that, we cannot recommend drug A.
So the summary is there is no real evidence like in other areas. We do not have direct head-to-head comparisons like in oncology. This is why they can rank different therapies. We really do not have this. Are there any ways to get around this? So something like the network meta-analysis, and we have discussed this heavily in the German society. What do you think about this? Could this be an approach?
A network analysis is a very good thing to give you a helping hand, but of course there's limitations. All what we just discussed, with PICO, with ranking of papers, and so on, is not done in the network analysis. They're just taking papers together, rank them, make a little square, and say, if you're in this situation, take this and that drug. I'm not sure how much evidence-based that is. It is a helping hand, but always you have to look for your patient, what kind of situation your patient has. And then what is the availability in your country? We in Germany have TNF codes. So we must treat our patients 55 or 60% with a TNF first. In other countries, maybe we don't have access to IL-23 inhibitors. So it's a little bit different in every country. Some countries do have JAKs, some don't. So it is a little bit different. But we should be open to change our medical treatment given on the evidence, and that's what guidelines are for.
Yeah, I think one of the key aspects is that it's a very complicated methodology, and like in the clinical trial where you can set up inclusion-exclusion criteria and can somehow create a result, you can do the same with network meta-analysis, and at least in Germany we're not feeling confident enough to really include the evidence generated from this for the sequencing process. And I think this may be probably very correct or not.
Of course. I think everything that's helped us to make good medical decisions are there. And one is, of course, meeting like this, OEG week. Others are papers, and one is guidelines. And everything, of course, are important, for treating our patients good and with a good consistency. I think this is what guidelines are for. You cannot, have a small bowel Crohn's disease with abdominal pain and don't give him an MRI. Guidelines clearly said you should do upper endoscopy, you should do MRI to be sure it is not a small bowel involvement. And that is why our patients have the right to be treated by the best scientific evidence, and that's what guidelines are for.
So finally, one point I would like to touch upon is the MDT. This is something which is always recommended, and we see it also in our other areas. Multidisciplinary team working. We mentioned that there is a multidisciplinary team creating a guideline. So this is probably something which also will really help to implement this into the real patient care or not.
You mean in daily practice?
Yes.
I think that is very, very important. So we do have the MDT once a week. We have first the cancer conference from 4 to 5, and then from 5 to 6, we have the IBD MDT with the surgeons and radiologists and pathologists. I think that is very important that we do have that. We do have complex patients. I don't think that you need MDT for easy to treat colitis patients with 5 A's.
Sure.
But if it's a complicated patient, A lot of physicians said, oh, IBD is interesting. I give him more or less steroids, and then they go on forth, and then we have horrible courses of IBD. We would never do that in hepatology. We would never do that in oncology. We give them to oncologist specialists. But in IBD, it's different. Everyone thinks I can treat them. I read a paper about azathioprine 25 years ago. Oh, I give them azathioprine. So I think MDTs are very, very important. And we do have the possibility, at least we do it with Teams meetings. So we like 15, 16 people from outside, physicians from outside, small private practices, bringing the patients in. We discuss it. We never saw the patient, and they can discuss with us if they're in small private practices.
Andreas, I think this was a very lively and great discussion. It was very entertaining, at least for me. And I think this is something we definitely need to repeat when there is a new guideline coming up, and going a little bit more detailed through the single steps of a guideline. Thank you so much for being with us, and hope to see you again for another IBD Essentials.
I keep you posted. Thanks.
Thank you.